Good evening, ladies and gentlemen, and I would like to congratulate the organizing committee and the Emirates Cardiac Society for this great initiative to promote cardiovascular health disease of women in the region and asking me to be part of this prestigious meeting. My topic today is to address microvascular disease, MINOCA and INOCA. Cardiovascular disease remains #1 killer both in the developed world as well as in the developing countries. And this is true for both men and women. Ischemic heart disease is estimated to affect 67 million women globally. It has traditionally considered a problem of post-menopausal women. However, annual evidence of acute myocardial infarction hospitalization has been increasing in the young women below the age of 55. And traditional cardiovascular risk factors play an important role in the development of ischemic heart disease in women. Women may experience 6 specific ischemic heart disease risk factors and pathophysiology. And women under the age of 65 suffers the highest relative 6 specific ischemic heart disease compared to men of the same age. And really, men and women are different. Men and women are different psychologically, physiologically, and one of the great non-medical books that I really promote and advise people to read is Men from Mars and Women from Venus, and it's really address how women and men are different. They are different in perceiving stimuli. They are even different when they are sick and how they can get disease. So cardiovascular disease in women, women are more likely to have atypical or non-anginal pain. Women are often, ischemic heart disease in women are often under-recognized and really underappreciated. Women more likely to be excluded from clinical trials. And the women have high prevalence of cardiovascular risk factors, and women have different plaque characterization. This is a post-mortem study of patients who had sudden cardiac death due to ischemic heart disease, and they looked into the plaque characteristics of men and women. And mainly in men, the plaque rupture usually had a necrotic core with an occlusive thrombi in men, whereas in women, it has an intact fibrous cap and early fibroatheroma. In the PROMISE trial, it's a CT trial. They looked into high-risk plaque features, which are positive remodeling, negative low Hounsfield unit, and positive napkin ring sign. And they found that high-risk plaque are more predictive of events in women and in patients of non-obstructive coronary artery disease. And we have heard earlier on that obstructive coronary artery disease is only the tip of the iceberg. There are more into ischemic heart disease, especially in women, especially in the microvascular circulation. And when we angiogram patients, we only see around 1 to 5% of whole of the coronary vascular volume. So non-obstructive coronary artery disease in women is quite prevalent compared to men, predominantly affecting young, middle-aged women, present with preserved ejection fraction, and there are often multiple mechanisms for ischemia. This is a Danish registry from 1998 to 2009 of over 11,000 men and women who presented with angina and went for coronary angiogram. And 50% of the whole cohort had non-obstructive coronary artery disease. 32% of them were men, and 65% of them were women. And when we tend an angiogram people with angina, we tend lump normal coronary angiogram to non-obstructive as one lump. But this is not true. Patients or symptomatic patients who have what is referred to as normal angiogram do not do well as patients who are asymptomatic. So if you can't just subdivide ischemic heart disease into two categories: chronic coronary syndrome and acute coronary syndrome. From the chronic coronary syndrome, there is obstructive coronary artery disease and INOCA, or ischemia with non-obstructive coronary artery disease. And in the acute category, patients with STEMI, unstable angina, and non-STEMI, and MINOCA, or myocardial infarction with non-obstructive coronary artery disease. And let's start with MINOCA, and the prevalence of MINOCA is around 7 to 15% in patients who comes with an acute coronary syndrome will have an obstructive coronary artery disease. And it really causes a diagnostic dilemma, and it is not a benign phenomena. There is about up to 4.7% mortality rate in the 12 months, and it has a great implication in your therapeutic options. Initially, it was identified as MINCA, or myocardial infarction and normal coronaries. And in 2013, it has been described as a syndrome or an umbrella of diagnosis, and the name MINOCA came into clinical practice. And since then, there has been evolution in the concepts and the recommendation from different society up to 2020 in the latest guideline, where MINOCA diagnoses to be really a true infraction. And when we categorize this, you can look into the causes of MINOCA into either atherosclerosis because of epicardial disease due to plaque rupture or erosion, or non-atherosclerosis due again to epicardial disease because of spasm, thromboembolism, or dissection, or microvascular disease due to microvascular dysfunction. And they proposed this very nice traffic light algorithm that help us to investigate patients in a systemic way in order to reach the correct new diagnosis of MINOCA. So you start with a true myocardial infarction definition. You do a coronary angiogram, or CT if you like. You exclude other and the patients have non-obstructive coronary artery disease, and you put the patient into the context. Does he have sepsis? Does he have pulmonary edema or pulmonary embolism, any other conditions that will mimic an acute coronary syndrome? Then you move into the working diagnosis, looking back into the investigation that is being done. You assess the angiogram again, you assess the LV function, you exclude other causes such as different types of cardiomyopathy, including Takotsubo cardiomyopathy. Then you consider advanced imaging modality such as cardiac MRI, where it can either diagnose, confirm the presence of an infarction or exclude myocarditis. Then you are down into the green zone of MINOCA. So the provisional diagnosis should be an acute myocardial syndrome. Angiogram is done, exclude significant stenosis, further evaluation. So MINOCA, in the real new MINOCA, myocarditis and other forms of cardiomyopathy has been excluded. And it's very important to try to utilize a maximum investigation that you have in order to reach the accurate diagnosis because of the therapeutic implication. The data in MINOCA itself is quite non-specific and general. Antiplatelets role is neutral. However, if there is plaque disruption, single antiplatelets or even dual antiplatelets is indicated. If a spasm is there, calcium channel blockers is indicated. And in patients of spontaneous dissection, we heard a great lecture about the treatment of that. Moving into INOCA, which refer to ischemia with non-obstructive coronary artery disease. And when we say non-obstructive, we either mean normal coronaries or obstruction less than 50%. In INOCA, there is a mismatch between the blood supply and the myocardial oxygen demand. It can be caused by coronary microvascular dysfunction or epicardial coronary arterial spasm, or known as vasospastic angina, or both. And when we look at the coronary anatomy in women usually have a smaller epicardial coronary arteries than men, even when adjusted for their small body habitus and left ventricular mass. Women have a lower prevalence of obstructive coronary artery disease, and they have different black characteristics. These 6 differences in coronary size and atherosclerosis development appear to contribute to the higher prevalence of INOCA in women. We have seen this nice picture by Professor Schifo looking into INOCA, and you can see that 2 main causes, vasospastic angina, which can be transient, causing Prinzmetal angina, or persistent, causing an acute myocardial infarction, or coronary microvascular dysfunction that is caused by impairing in the coronary physiology and myocardial blood flow due to multiple factors, obesity, diabetes, high blood pressure, and other risk factor causes microvascular angina and contributes to myocardial ischemia and coronary artery disease. Patients with INOCA usually present with a wide spectrum of symptoms and signs that are often misdiagnosed of non-cardiac origin. Patients at highest risk for coronary microvascular dysfunction include women, those with hypertension, diabetes, other insulin-resistant states, and it has a higher prevalence in patients with anxiety and depression. Patients with INOCA usually have worse quality of life compared to patients with obstructive coronary artery disease. And coronary microvascular dysfunction usually is the main cause in patients with refractory angina, and even in patients post revascularization, CMD can be the culprit of their symptoms. In CMD, pain may be precipitated by effort, but also it can occur at rest, particularly in the presence of coronary microvascular spasm as a pathogenic mechanisms. Patients may present with atypical symptoms such as dyspnea, fatigue, or picture of dilated cardiomyopathy. In this study of over 1,000 symptomatic women who was referred for non-invasive evaluation because of symptomatic angina, they end up having a normal PET scan. However, when coronary flow reserve has been done, found out that CMD was present in around 67% of women compared to men. And it is not a benign disease, and patients usually are associated with worse prognosis. This can be measured by using the coronary flow reserve, which integrate effect of epicardial coronary artery disease, diffuse atherosclerosis, and microvascular dysfunction. And what you do is you measure the maximum blood flow during hyperemia compared to the maximum flow during rest. And the number you're looking for is less than 2 or 2.5. There are different ways of doing that. You can do that invasively, and you can also do that non-invasively. So the management of patients with INOCA starts with looking into lifestyle factors and try to modify risk lifestyle such as obesity, such as sedentary lifestyle, treating depression, treating hypertension, and then looking further into risk factors, treating their diabetes, treating their dyslipidemia and hypertension, into anti-anginal specific medication depending on the underlying diagnosis. So, ladies and gentlemen, to conclude, ischemic heart disease is common in both men and women. Ischemic heart disease in women is under-recognized. Women are more likely to have atypical or non-anginal pain and non-obstructive coronary artery disease. Correct recognition of MINOCA is important to initiate the appropriate management. INOCA is a major health problem associated with underdiagnosis, undertreatment, and poor prognosis. Thank you.
Thank you very much, Dr. Safaa.